So welcome everybody. I'm Heather Studwell. I'm the Oncology Survivorship Coordinator down at Smilow, Greenwich. Joining me tonight for our first of 4 series for our breast education event is Dr. Lotfi and Dr. Sheiman. And we're going to be talking to you tonight about screenings and lymphedema and radiology and advances in breast cancer. So I will get started by introducing Dr. Lotfi. She is the Assistant Professor of Radiology and Biomedical Imaging. She's a fellowship trained breast imager and with more than 20 years of experience in all of breast imaging modalities, which include tomosynthesis, ultrasound, breast MRI, and contrast enhanced mammography, as well as all image-guided procedures. She has extensive teaching and leadership experience. Most recently, she was the director of the breast section's clinical operations at BIDMC and the director of Connecticut Breast Imaging. Her interests include improving workflow, maximizing efficiency, and new technologies. She is passionate about providing patient-centered, high-quality care working within the multidisciplinary team of experts. So Dr. Lotfi, I will turn it over to you.
Thank you so much for that lovely introduction. I'm going to spend a very short period of time, about 15 minutes or so, speaking about the recent or the latest guidelines for screening, breast cancer screening in our patients. I'm going to share my screen now. And let's hope this works. Yep, do you all see that? Yep, we're good?
Yes.
Okay, perfect. All right, just to give a little bit of background in terms of statistics, this is the latest 2023 SEER data. And there is an estimated new cases of breast cancer that's approximately 300,000 per year. This is about 15% of all new cancer cases. And it's estimated that about 43,000 women will die from breast cancer this year, which is about 7% of breast cancer diagnoses. This is a graph that is, again, SEER data showing rate per 100,000 on this side, and it's broken down breast cancer by age. And you can see this is, I mean, I'm sure a lot of this information is not new to you all, but just to see that there is very few breast cancer cases below age 30, but then the incidences do pick up steadily and kind of peak at about 74, which seems to be the magic number. The incidences do decline after that, but you can see that there is breast cancer in all ages. Old people still get breast cancer, as far as we know, into their 80s, as we have data. And the incidences in women 40 to 54 is not small. People do get cancer in their 40s, and I'll talk more about that. So screening mammography, which is the gold standard for decades, we've had data from screening mammography showing that it saves lives, and basically the mortality reduction is the key factor that brought screening mammography forward as our main tool. Obviously, when we find cancers on screening, any kind of modality, but particularly mammography, we find them smaller than if they present clinically. Therefore, the treatment is less aggressive, generally lumpectomy, hoping lumpectomy versus mastectomy. Often less chemotherapy is required. And also, when we have screen-detected high-risk lesions, for example, atypical ductal hyperplasia, this allows for a discussion of providers with the patient regarding options to decrease that individual's risk and therefore decreasing their morbidity and mortality. The discussion may include increasing imaging surveillance, clinical surveillance, risk reduction medications, or other interventions. There have been, again, going back decades, randomized controlled trials, national population-based data, and international service screening programs that have shown screening mammography to provide a decrease in mortality of 20 to 49% across all ages. There are numerous more recent studies also that have shown a reduction of 25 to 50% in cancer-related death in 40 to 74-year-olds. This is not news to us. Everybody knows that screening mammography decreases mortality and saves lives. This graph is basically breaking down the mortality reduction by age. And if women get screened starting at 40, going to 84, there's a 40% reduction in mortality compared to 31% if women get screened starting at 45 to 54, and then every other year, 55 to 79. And lower than that, 23% in mortality reduction if women get mammograms every other year, starting at 50. So this brings us to the latest screening guidelines. This chart is a comparison for average risk women. And it's a little busy, but I'm going to start from the top, which is the gold standard for us, American College of Radiology and Society of Breast Imaging. Advocate women getting mammograms starting at 40 annually, and there's really no age limit. Basically, we need to tailor to individuals and make decisions based on their health status. I'm gonna then talk about the USPSTF, the United States Preventative Task Force, which basically changed its recommendation and lowered the age of starting mammography from 50 to 40 just recently. And they're still advocating every 2 years, and they have a hard stop at 74. Then every other society in between, American Cancer Society, American College of OB-GYNs, AMA, American Society of Breast Surgeons, they pretty much all advocate starting at 40, some 1 to 2 years, and but for the most part, 40 to 45 is the rest of the recommendations. Again, ACR and SBI recommend starting 40 annually. This is not new. We've always said that. It's the USPSTF recommendation that just recently changed. So I want to talk about what I call screening drawbacks. Some literature states screening harms, which I really don't like that word because it's not so harmful. But like anything else, there is pros and cons. And one of this is recall rates. Recall rates, as you all know, is basically when a woman has a screening mammogram, they're asymptomatic, they get a screening, we see something that may or may not be cancer, it's just an abnormality, it requires further evaluation, we call them back. The recall rate on the average is 10%. It goes down with experience, it goes down with people who use tomosynthesis, but it's quite variable. And some of the other factors that make it variable is a patient's age, their breast density, busier breast, can vary in appearance from year to year and therefore require further evaluation. If someone has had prior cancer history, they have a family history of breast cancer, they've been on estrogen, and also if we don't have previous mammograms for comparison. There's been a lot of mobility recently. I see it in Connecticut, and I've seen it from elsewhere. People are moving since COVID from state to state and often do not bring their previous mammograms with them. So this can lead to a higher recall rate. Anxiety is one thing that the US task force had mentioned previously, that this is a major negative for recommending annual screening and also screening women younger than 40 previously. Anxiety related to screening is a real thing, but it's really short-lived. And a recent study just showed that when women were talked to about potentially not getting screened because of the degree of anxiety that they experience, 86% said no, they can handle the anxiety. And if women get mammograms for about 10 years annually, about 50% of them will get a callback or a so-called false positive. There are ways to remedy the screening anxiety. The sooner we read the screening mammogram, the less anxiety women will suffer from. There are some centers that hope for same-day results. Doesn't have to be in person or online, but it can be done via text or immediately in the patient's portal. It's really not possible in busy centers, and even more so the anxiety from getting a call back and then potentially a biopsy, which can have a lead time of weeks, is a real issue for women. Radiation exposure is essentially nothing we worry about on a daily basis. The radiation that women get, even from a 3D mammogram, is quite safe. And it's equivalent to about 2 months of natural background radiation someone can get exposed to. Patient discomfort, obviously during mammography, it is uncomfortable, but it shouldn't be a harm or a reason for women not to have mammograms. Overdiagnosis is basically cancers that will never cause symptoms, either because they don't grow at all or because they grow slowly and the patient dies before the symptoms ever become apparent. The numbers are quite variable, but it's supposed to be less than 10%. So we know women get cancer. We know all ages of women get cancer. We just don't know which cancer is going to be aggressive and which one is going to be slow growing. So as far as screening is concerned, we can screen and we can detect. Now, how we approach the treatment is what I think should be discussed and managed on a case by case. As women get older, we know that they have all kinds of morbidities, but we don't tell them that because you're old, we're not going to treat your diabetes or your hypertension because you're old. I think a discussion is warranted, not a hard number for when to stop mammography. I'm going to just quickly go over the screening guidelines for high-risk patients. And I've started with the more uncommon scenarios that we see. And I'll go more into the more common scenarios. Women who receive mantle radiation between ages of 10 to 30 need to get screened much earlier, because during those ages, the breast buds are quite radiation sensitive, and we need to screen them for cancer earlier. We usually go back about 8 years before, after they stop radiation, but not before 25. And at 25, we recommend annual breast MRI as well. The genetic carriers, other BRCA1 or 2 or other gene carriers, and then their untested first-degree relatives need a mammogram starting at 30 and annual MRIs 25 to 30 years of age. The latest ACR recommendation, American College of Radiology recommendation, says that if women are already getting MRIs early on, then they can wait till 40 to get the mammogram. Women who have had a calculated lifetime risk of breast cancer that's more than 20%, this is predominantly based on family history, should have an annual mammogram and annual MRI starting at 30. Women who have biopsy-proven lobular neoplasia or atypical ductal hyperplasia or high-risk lesions need annual mammography at the time of the diagnosis moving forward, and MRI if they have other risk factors increasing their risk. Women with personal history of breast cancer obviously need an annual mammogram. And this is a new ACR recommendation again that says if women have dense breasts, regardless of their age, need a breast MRI annually. And of course, if they were diagnosed before 50, regardless of the density, need a breast MRI. Additionally, the ACR recently recommended that high-risk women who need supplemental screening but cannot undergo MRI screening should consider contrast-enhanced MRI, mammography, or ultrasound, and that risk assessment for all women should start already by age 25. This is a clinical risk assessment. Speaking of contrast-enhanced mammography, I just wanted to show everyone what that looks like, because some may not have seen it. When I was in Boston, Bethesda Real Deaconess Medical Center was one of the first centers to start contrast-enhanced mammography. We weren't yet using it for screening purposes. It was mainly diagnostic, but for patients, but we were doing it as part of studies for screening. And this is an example of a mammogram which is quite dense. No mammographic abnormalities were identified on this one. And this is the contrast mammography portion of this study, which shows the intensely enhancing mass in the upper outer quadrant of that same breast. And just to let you know, contrast-enhanced mammography is basically poor man's MRI. That's what we used to call it. It involves injection of contrast intravenously, and the contrast is the same as we use in CAT scan. And we get a mammogram pre and post injection. Subtraction happens with a dedicated software, and this is what we're left with, which is quite amazing. And this chart basically shows why supplemental screening is important. And my colleague Laura is going to talk about dense breast, but I just want to bring it to your attention. Our gold standard being 2D mammography, tomosynthesis or 3D mammography for dense breasts can add from 1 to 3 additional cancers, can find additional cancers per 1,000. And if we do ultrasound in the same density breast, dense breast, we find an additional 3 to 4 per 1,000. And contrast will find on average additional 10. This is all additional to 2D. For the most part, Yale and other centers in Connecticut are doing 3D mammography. So already we have an advantage. And MRI or abbreviated MRI will add 16 or 17, which is really remarkable. And some advocate that women with dense breasts should have MRI, but we all know that that is just not possible. Briefly, I want to touch base on screening, specifically Blacks and minorities. This topic has gotten a lot of attention recently because it needs to. About 42% of Blacks and minorities are 42% more likely to die from breast cancer, despite roughly equal incidence rates. They're less likely to be diagnosed with stage 1 breast cancer, but twice as likely to die of early breast cancers. They have a twofold higher risk of aggressive triple-negative breast cancers and a high risk of BRCA1 and 2 genetic mutation. Before age 50, these women are 127% more likely to die from breast cancer, 72% more likely to be diagnosed with breast cancer, and 58% more likely to be diagnosed with advanced stage breast cancer. These are all compared to whites. So the reasons are multifactorial. It could be access to mammography or lack thereof, healthcare delivery patterns, and tumor biology. But the point is, risk assessment and imaging should start much earlier. The conversations with these types of patients, Blacks and other minorities, should happen much earlier. And basically, just to summarize, it's important we all and the clinicians understand the risks and the benefits and the uncertainties of mammography and other screening tools, and incorporate patients' values about those risks and benefits. And decision making should include assessment of that individual's cancer risk, a discussion of risk and benefits in that context, and their preferences. And I thank you for your time.
Thank you, Dr. Lotfi. So we had one comment in the chat from Dr. Ward. She said that she tells elderly patients if they can drive themselves to their screening mammogram, they are likely healthy enough to benefit from it. Do you agree?
I do agree. If they are healthy and they're interested in staying healthy and living longer. We have longevity. You know, I see a lot of women in their mid 80s, late 80s, early 90s who are good. They're healthy. They are cognitively healthy, physically healthy. And I personally don't tell them what to do, but I do say that you need to discuss this with your family, with your primary care physician. And as long as if we were to find a cancer, you want to treat it because you think you're good enough to undergo treatment and have the life expectancy, absolutely come in and get treated. I don't want to be ageist. Old people get cancers and they deserve to be treated.
Great. Okay, so we will move on now to Dr. Sheiman. She's the Assistant Professor of Clinical Radiology and Biomedical Imaging. She's also the Section Chief of Breast Imaging. She is a board-certified radiologist specializing in breast imaging. Her clinical expertise covers all aspects of breast imaging, including screening and diagnostic mammography, breast ultrasound, breast MRI, and image-guided breast procedures. Her interests include patient experience, patient-physician communication, and quality improvement. So thank you.
Thank you. I'm going to share my screen here. Okay. And hopefully everybody can see that. So thank you for having me tonight. I'm going to be discussing breast density, a topic that you may be hearing about a little bit more in the news, especially in the month of October with breast cancer awareness. So first, what is breast density? What are we talking about here? So breast density is a measurement of the amount of fibroglandular tissue in the breast relative to the fatty tissue. So every woman will have a mixture of these two types of breast tissue in the breast. And it's as more of the breast has more of that fibroglandular tissue, that is what we are calling increased density on the mammogram. So this is assessed and reported with every single mammogram. And of note, it has no relationship to the appearance of the breast or to the firmness of the breast on physical exam. It can only be assessed by imaging. So we place every patient into 4 categories of breast density, and this is as dictated by our BI-RADS lexicon, the language of breast imaging. So there are 4 categories. Sometimes they're referred to by the letter category. So category A, the breasts are almost entirely fatty. Category B, there are scattered areas of fibroglandular density. Category C, the breasts are heterogeneously dense, which may obscure small masses. And category D, the breasts are extremely dense, which lowers the sensitivity of mammography. So you would see one of those 4 statements on every mammogram. I'm a radiologist. I like pictures. And so here are examples of women in each of those categories with all the way at the left side of your screen, patient with predominantly fatty breast tissue. Next, we have patient with scattered areas of fibroglandular density, then on to heterogeneously dense. And then all the way at the other end, patient with the most density in the extremely dense category. So we put the patient into one of 4 categories of breast density by the mammogram. But when we talk about this kind of overall category of dense or not dense, there's a dividing line down the middle. So patients in the category A or B will be considered not dense, and category C and D patients would be put into the category of having dense breast tissue. So makes a difference certainly in terms of how this breast density is determined. So how do we do this? For many years, this has been a subjective assessment by the radiologist. We look at the mammogram and kind of just assess that ratio visually. The only issue with that is that each radiologist will have a slightly different threshold for calling a patient dense. And we'd like to have it be more uniform so that year to year and radiologist to radiologist, there's agreement on the breast density assessment. So there are tools now available that allow for automated computer-based assessments for breast density in order to make that density assessment more reproducible and less subjective. So here's an example of a patient on the left. I think pretty much every radiologist would agree that this patient has dense breast tissue, and I would put her in the extremely dense category D. And you can see that my breast density tool also puts the patient into category D with a 94% certainty of that classification. On the other end of the spectrum, the mammogram on the right is that more see-through type mammogram in a patient with predominantly fatty breast tissue. And the breast density tool has agreed, putting the patient into category A. So in our practice, we get this little box that pops up telling us what the computer has assessed the breast density to be for every mammogram. So that's great when everybody is in agreement. The problem is a lot of patients don't neatly fall into one of those categories. So here is an example of a patient that I think meets that kind of borderline assessment. If you ask a number of radiologists, I think some would say that this patient has dense breast tissue and others would say this patient does not have dense breast tissue. So you turn to the automated breast density assessment, and that doesn't really help that much either, having given a different breast density for the left breast versus the right breast there. In our reporting, we don't give a breast-specific density, so you wouldn't see that the left breast has scattered areas of fibroglandular density and the right breast is heterogeneously dense. We give one overall assessment of the breast density. And so this is the kind of patient that maybe from year to year may be told that she has various breast density depending on the individual radiologist and their subjective assessment. So why does this matter? Why do we really care if that patient's put in a category of having dense breast tissue or not dense breast tissue? Well, for starters, women with dense breast tissue are at an increased risk for breast cancer. And this is thought to be an independent risk factor for the development of breast cancer. It's a little tricky because about half of the screening mammography population will have dense breast tissue. And so it's tough to really determine the effect of breast density alone, since it's such a significant amount of the population undergoing mammography. But when we look at the extreme ends of the spectrum, it's thought that the difference between a woman with predominantly fatty breast tissue and those with the most density in the extremely dense category, that those women with that extremely dense breast tissue may have about a 4 to 6 times increased risk for developing breast cancer compared to a woman at the far end of the spectrum having not dense breast tissue. The next issue is that dense breast tissue makes it harder to detect cancer on a mammogram. So most of the presenting signs of cancer, whether it be a mass or a group of calcifications, appear white on the mammogram, and they can be obscured by that dense breast tissue. This is the masking effect. We frequently refer to it as the masking effect of dense breast tissue. And some will liken this to try to find like a snowman in a snowstorm. But however, whatever analogy you want to use, as the breast tissue becomes denser, it becomes more difficult for the radiologist to detect a cancer on the mammogram. And I just want to note that this is true both on the 2D and the 3D or tomosynthesis imaging as well. So increasing density, although the tomosynthesis imaging is helpful, is still less sensitive with tomosynthesis as well as the 2D mammography. So with those limitations in mind, supplemental screening is frequently recommended in women with dense breast tissue. And Dr. Lotfi was just addressing some of this. A question I get asked a lot is, I have dense breast tissue, so now I don't need the mammogram, right? And that's not true. At this point in time, the mammogram remains the gold standard exam for breast cancer detection. I think as a field, we're always trying to reevaluate what the best imaging options are, but that at the moment is the gold standard test. But women have options when it comes to supplemental screening. So in our population, most of our patients will undergo supplemental screening with whole breast screening ultrasound. Women with genetic predisposition, a higher overall lifetime risk of breast cancer, more frequently undergo contrast-enhanced breast MRI. And as Dr. Lotfi had mentioned, there's additional technology really more up and coming with things like contrast-enhanced mammography. I would say in our population, ultrasound is readily available. Most of our patients will schedule their screening mammogram and screening ultrasound back to back. It can be done in the same office at the same visit. Doesn't require an IV or contrast administration. And so it is quite popular. And I think Connecticut in general, screening whole breast ultrasound is popular in our area of the country, but it is less sensitive compared to those contrast enhanced exams, as Dr. Lotfi had shown in her slides. Here is an example of a patient who, 73-year-old woman, came in for her screening mammogram and screening breast ultrasound. And so you can see that she does have extremely dense breast tissue on her mammogram. This was done as both a 2D and tomosynthesis screening mammogram. And she had her screening ultrasound pretty much immediately following her mammogram. And at that point in time, she was found to have this irregular mass in the left breast. That was felt to be suspicious by imaging, underwent ultrasound guided biopsy, and subsequently was found to have a 6 millimeter invasive ductal carcinoma. So she went on to have lumpectomy, breast conserving surgery, and did not have any axillary lymph node involvement at the time of her surgery. As somewhat of a companion case, this is an example of a 74-year-old woman who came in with a palpable lump in the right breast. And when a woman comes in with a palpable complaint, we ask them to point it out and put a little sticker that has a triangle marker over the area. So you can see the triangle marker that overlies the patient's upper outer quadrant of the breast. And the mammogram was felt to be normal, even in retrospect, on additional, review, knowing where precisely to look again, we did not see what was found to be a breast cancer there. Because of the diagnostic nature of her exam, that she came in with this symptom of a palpable abnormality, she went on to have her ultrasound, and that showed an 8 millimeter hypoechoic mass in the breast. She underwent ultrasound guided biopsy. You can see where that biopsy clip landed on her mammogram after that. And this patient went on to surgery and was found to have a poorly differentiated triple negative invasive ductal carcinoma. And she did have axillary lymph nodes that were positive for carcinoma at the time of surgery. So we wonder if we could have, found this before the axillary lymph nodes were involved. So now you've heard about the importance of breast density. And so women should know what their breast density is. Connecticut was really at the forefront of this. We were the first state to require notification about breast density in 2009. And this story is really one of Dr. Nancy Capello. You can't discuss this density notification law without talking about her, since she was really a force behind this. So her story was that she went in for her screening mammogram and was told everything's fine, see you for your next screening. And then 6 weeks later, on her physical exam at her doctor's office, they found a lump in the breast. So she went back for diagnostic imaging at that point in time, which included an ultrasound. And lo and behold, they found a breast cancer where her doctor had felt something in the breast. And she just thought to herself, how could this be? How is this possible that I just had a normal mammogram and now I'm told that I have breast cancer? How does this make sense? And so it became part of her mission to have women be informed of what their breast density is and, some of the options of what they can do for additional screening options. So over time, there's been a hodgepodge of different state legislation. Connecticut was first, but many states followed. And the language and requirements for breast density notification varied from bill to bill across the country, and not every state has a breast density notification at this time, but that is all about to change because in March of this year, the FDA issued its first national requirement for breast density notification, and this falls under MQSA, which is the Mammography Quality Standards Act that all radiology facilities are under. So nationwide, all radiology practices will have to comply with this breast density reporting requirement by September 10th, 2024. The new breast density statement, I'll just read the dense breast tissue notification. It will read, breast tissue can be either dense or not dense. Dense tissue makes it harder to find breast cancer on a mammogram and also raises the risk of developing breast cancer. Your breast tissue is dense. In some people with dense tissue, other imaging tests in addition to a mammogram may help find cancers. Talk to your healthcare provider about breast density, risk for breast cancer, and your individual situation. So now it will be much more uniform across the country what women are told, specifically after they have a mammogram showing dense breast tissue. So some women, they hear that they have dense breast tissue, and the first question I get is, what can I do to get rid of it? I don't want to be in this category. Is there anything I can do? And the quick answer essentially is no. Dense breast tissue is associated with younger age, a lower BMI, a use of hormone replacement therapy, and even a family history of dense breast tissue. So there's not much you can do about your age. I would never encourage a woman to gain weight to change their breast density. That won't be good for their overall health. And so it's kind of out of your control. Some women will never be in that not dense breast tissue category. It's just unique to each individual. The one sort of option that women would have would be if they were on tamoxifen as chemo prevention in women with a higher risk of breast cancer, as that does show a decrease in breast density on the mammogram. I just want to reiterate, though, that a woman can be told that they have dense breast tissue on a mammogram at some point in time, and on a subsequent mammogram, they may be told that their breast tissue is not dense, and they may no longer need supplemental screening at that point. I think that can be a little confusing, but the breast density, generally the normal tendency is for it to decrease with increasing age. Here's an example of a patient whose breast density did change. So the mammogram at age 65 shows that she has heterogeneously dense breast tissue, but by age 73, probably mixed in with a little bit of weight gain and increasing age, her breast density would be placed in a category of no longer being dense. So in summary, the denser the breast tissue, the less sensitive the mammogram. Women should be aware of their own breast density and what it means, and women with dense breast tissue should discuss supplemental screening for breast cancer in addition to routine mammography. Thank you.
Thank you so much. We do have one question. Do you see a day when the probably benign language will change for a 6-month follow-up? And could it be likely benign?
Oh, yeah, I think that some people do not like the probably benign terminology, especially because if you ask women what kind of risk they think is associated with a BI-RADS 3 probably benign assessment, they tend to overestimate their concern that that could be cancerous. So I could see that in a future edition of BI-RADS.
All right, so I am up next. I'm going to introduce myself again, this time with my, prior to my role as the oncology survivorship coordinator, I'm also an occupational therapist, and my specialty is, I'm an oncology rehab specialist with a board certification in lymphedema treatment. So I am going to now share my screen. Second. Okay. And talk to you about lymphedema surveillance in breast cancer. So I'm going to do a quick review of the lymphatic system and what it is, what it does. So the lymphatic system is part of your body's circulatory and immune system, helps to keep our body healthy. It provides a balance of fluid in the tissues by transporting proteins and digested fats to provide your cells with nutrients. And it also is there to help to fight infections. What does the lymphatic system do? It moves the lymph fluid towards the heart through a network of lymph vessels and nodes. Your lymph fluid is a clear liquid made up of water, proteins, fats, white blood cells that fight infection. Your lymph vessels transport and drain lymph fluid back to the blood system and to the heart. And those lymph nodes filter out bacteria, viruses, other germs, and waste to help keep you healthy. And what helps our lymph flow? Moving your muscles, doing deep diaphragmatic breathing, lots of laughing, and a special kind of gentle massage that we call manual lymphatic drainage. And what's happening that's causing the swelling? When your lymphatic system is healthy, your body moves its lymphatic load very well, and there usually is no tissue swelling. If your body is not able to move the lymphatic load well, there's a buildup of fluid and tissue swelling can happen. And this is what can happen and what will happen. Sometimes it can be lymphedema. So what is lymphedema? It's that abnormal accumulation of that protein-rich lymph fluid in the tissue, which can result in the swelling of a body part and also can cause fibrosis in that area. So lymphedema affects about 250 million people worldwide. It's a mechanical failure in the lymphatic system. The most frequent cause of lymphedema in the United States is secondary to a cancer or cancer treatments. There are two categories of lymphedema. There's primary lymphedema and there's secondary lymphedema. And I'll go over what each of those mean. There's 4 stages to lymphedema. Looks like stage 3, and there would only be 3 stages, but stage 0 is actually our latent subclinical population. These are the people who are at risk for getting lymphedema. They may have had nodes removed or surgery or trauma, and they don't show any clinical signs of lymphedema. There's no visible swelling, but we would call that, we categorize that as stage 0, and then it goes up to stage 3. So what is primary lymphedema? Well, this occurs when a person is born with a faulty lymphatic system. The signs of lymphedema could be present at birth, or they could develop during puberty or a little bit later on in life. The later development may be due to changes in the hormone or body weight that puts more of a burden on the lymphatic system. Many times we see primary lymphedemas come around that puberty age and then after the age of 35. More common in women than men, and it's more common in legs than any other body part. In secondary lymphedema, that occurs when a person's lymphatic system is damaged by surgery or radiation or some kind of injury. It can develop a short time after the damage occurs or many years later. It may also develop due to surgery that's not related to cancer. And other causes such as trauma, recurring infections, venous insufficiency, and obesity are also causes of secondary lymphedema. So what we're going to talk about tonight, breast cancer related lymphedema, is considered a secondary lymphedema. So who's at risk for getting breast cancer related lymphedema? Well, it's anybody having axillary management or axillary nodes dissected, somebody who's had radiation therapy, somebody who's been on systemic chemotherapy, more specifically the taxane-based chemotherapies. And more at risk are people who have their patient-specific factors like obesity, so a higher BMI than 30. If somebody has a family history of lymphedema or swelling, and a past surgical history. If somebody's had lymph nodes removed 20 years ago and they're having more lymph nodes removed now. If you have lymph nodes in both axillas removed, you're at a little bit of a higher risk as well. And what's changed over time is years ago when they did breast surgery, they did full axillary node dissections, and then advances in surgical techniques. Now we use the sentinel node biopsy, which has an incidence of about 4 to 6% for somebody getting lymphedema. So if you have just a sentinel node biopsy, your chance of getting lymphedema is very, very low. If you have an axillary node dissection with radiation, without, with systemic chemotherapy, sort of grossly any other kind of axillary dissection with some other kinds of treatment, or just an axillary dissection alone, your chance of getting lymphedema is up to about 42%. Typically, with breast cancer lymphedema, it occurs most often within the first 5 years after the breast cancer treatment. But what we see a little bit more of now isn't lymphedema in the arm, but with the use of sentinel node biopsies, we start to see a little bit more of breast lymphedema. So for someone having a lumpectomy with a sentinel node biopsy and radiation, their arm is not getting lymphedema, but their breast may get lymphedema. So when we look at those drainage territories and what happens, the at-risk region is the area where the lymph nodes were removed or damaged. So it develops in the part of the body around that area. So you'll see in red outlined here is what we call the watershed areas. And this whole area, because of that axillary node infarct, is where the swelling can be. It can be in the chest, it can be in the arm, it could be along the back or along the side of the trunk, because that's the pathway, that's the area that drains the lymph to those nodes. And we know that lymphedema represents a significant morbidity for patients who experience it. What does it feel like? It can be tightness or heaviness in the limb. It can be an achy feeling, tenderness in the elbow or wrist. Sort of patients will describe just odd sensations in their arm. Pain, the pain from congestion, just being full, discomfort. It's not necessarily unbearable pain. If somebody has lymphedema with unbearable pain, we usually look for something else, maybe an infection that might be brewing. And it's not the same type of feeling as when you have a sore muscle. So just looking a little bit at what a mild case of breast cancer lymphedema would look like, you'll see this is somebody who has a pretty much throughout the whole arm, and including a little bit on the top of the hand, not so much in the fingers. This is a separate picture. This isn't the same person, but somebody who has what we call the pitting edema, which be a little further along in her stages. But this, somebody can get lymphedema just from the elbow down, or it could be just in the hand. A lot of times it is worse around the elbow where the pathways of the lymph vessels travel across. Sometimes it's just in the upper arm. And like I said earlier, sometimes it's just in the breast. And how do we help these patients? We have a comprehensive lymphedema treatment program. The treatment protocol during phase 1 is it's 5 days a week. They come in, we do manual lymphatic drainage, we do compression bandaging, we give them an exercise program, we give them education on proper skin care and infection prevention, as well as home maintenance instruction. And then once we've reduced the size of their arm, they are fitted into a compression garment for daytime use, for nighttime use, and then they're seen routinely for follow-up care. At Greenwich, this is how we've always run our lymphedema program. We've been very fortunate to have physiatrists to see patients and support our programs. We have very dedicated and passionate lymphedema therapists. We've continued training and education, and we really get excellent treatment results for our patients. And because of this, our program has expanded to improve patient care and outcomes over time. And one of the things that we started doing back in 2013 was a prospective surveillance for lymphedema. So a patient would come into the clinic and, they would say, well, why didn't anybody tell me this could happen? And, what could we have caught it a little bit sooner? Or could we see lymphedema coming on sooner? Could we catch it earlier? And maybe it wouldn't get as bad. And so one tool that came out kind of around 2010 or 11 was something called the LDEX. And this was bioimpedance spectroscopy. It's a technology. It was a small machine at the time that measured through low frequency how the fluid levels were compared one arm to another. And it allowed for early detection of lymphedema by measuring the extracellular fluid underneath. So it does this by passing a very low level current through the body fluid and measures the body's impedance to the flow of that current that's going through. So you'll see in the picture with low level frequencies, this current cannot pass through the cells. It kind of goes around the cells. And then, but with high frequency, it actually does go right through the cells. So this lots of low level currents go through the tissue. And what that does is it gives us a number detecting in one arm versus the other arm, how much fluid is in there. So it can detect changes in fluid from one side to the other as small as about 2.5 tablespoons. It's been validated with lymphangioscintigraphies. And what we look for as therapists are any changes greater than 6.5. So we're going to come back to this chart in a little bit, but what this accurate detection and early detection does is it will tell us if there's swelling, something's increasing, if that fluid level is increasing before we actually see swelling. And with that, we can actually start them in a treatment program. We can start teaching them how to do self-lymphatic drainage. We would fit them with compression, and that would kind of keep them there. Or if their numbers were a little bit higher, it might actually push them back into the healthy zone of where they should be. So we started doing this at Greenwich in about 2013. And over time, we have upgraded our equipment to the newer version of the LDEX, which is now called, it's the SOZO with LDEX technology in it. And this is what the Sozo machine looks like. It's more sophisticated. It's got better accuracy. It also provides us with additional outputs and does a total body composition analysis, which we can use for, we can see how hydrated a patient is. It allows us to see what their percentage of muscle mass versus fat mass is. But for just detecting lymphedema, it will allow us to detect it with much more accuracy. And so at Greenwich, we put our patients who are having lymph nodes removed into our lymphedema surveillance program. And what that entails is we get their baseline measurements, what their normal lymphatic flow is before they have surgery. So they come into the clinic before they have their surgery, we put them onto the LDEX, we take their measurements, then we see them about 1 month after their surgery, which typically is good timing for before they start their radiation if they're having radiation. And it's usually before they're going to start any of their chemotherapies. And then we follow them over years after, and that, depending on how many nodes they've had removed, typically the protocol is for the first 3 years, we see them every 3 months. For years 4 and 5, it goes to every 6 months. And then from there on, it's annually. If there are no changes, this is the protocol. It's a very quick 30-second test. The patient just stands bare feet, bare hands. They keep their clothes on, but it's very quick. And so what happens if somebody comes in, maybe this here is their baseline, the green is normal, the yellow is actually normal as well. But what the yellow tells us is something's changing enough, and this is an area that we start to see our patients in the clinic. We want to be able to, we may not see the swelling, but something is changing enough where they've made a pretty significant jump into that yellow zone. So we'll put them into a compression sleeve. We'll teach them how to do self-lymphatic drainage. We'll teach them some decongestive exercises, and then we'll have them come back in about a month to see if we can't get those numbers with compression back down into a normal, into the green. If somebody triggers up into the pink, this is an area where typically we're already seeing swelling at this point. So this person who might have jumped all the way up into the pink, they're going to go into the regular lymphedema program, which was the phases that we talked about earlier with the wrapping and the daily treatments. But what we want to not necessarily avoid, but what we want to keep is them into, what we want to keep them into is this lower into the green part. And we've been able to do that by getting treatment in early. And it doesn't have to be the full treatment. And in 2022, the largest randomized control trial to assess lymphedema prevention was published. It's called the PREVENT trial. It followed about 1,200 breast cancer patients over 3 years. They compared measurements using the LDEX, some circumferential measurements. When we see a patient who has swelling, who has lymphedema, we take measurements every week to show their progress, to show the change. And we do this every 4 centimeters up the limb, and then we calculate it to give us a volume in the arm. So they use that technique with the Sozo and the LDEX technology. And what they found was 92% of patients who triggered, which meant went into that yellow zone, did not progress to chronic lymphedema, which would have been more into that pink zone. So they were able to keep their numbers from progressing by providing the compression sleeve, lymphatic drainage, self-taught, and exercises. So what does it all mean? Early detection will help these patients. It can stop the progression of lymphedema. We have an opportunity to see swelling before we see swelling. We can get them in early, very similar to having a mammogram. If you can diagnose it earlier, the treatment on the other side of it is less. And we know from another study done at the University of Kansas, they looked at percentage of lymphedema resolved with early detection and intervention, and 100% resolved in that subclinical. Only 88% or 88% resolved that had gone into stage 1, where you could see lymphedema. When you go into that pink zone where it's irreversible, it's not going to resolve. You're going to have to learn how to manage it after that. So by using the early detection from the LDEX, we can keep our patients in this area. By treating early, we also help these patients avoid the impact of chronic lymphedema, which can include psychosocial impact. This is something that they're going to have to manage for the rest of their lives. They're going to have to come in for therapy. They're going to have to do therapy on their own. They have to wear garments, sometimes 24 hours a day. It can trigger a lot of insecurities. Sometimes you can't wear, or women won't wear a long sleeve shirt because they have it. Sometimes it's discomfort. It's limited mobility, depending on how big or how involved the lymphedema is. And there's also an increased risk of wounds and infection as well. And there's also the cost to patients. So the out-of-pocket cost annually for a breast cancer survivor with lymphedema is a little over $3,000. There's co-pays for treatment. If you had to come in daily treatment 5 times a week, you're paying a copay every time you come in for that treatment. So I'm going to give you an example of a patient of mine. She was, prior to her breast cancer diagnosis, at 44, she was a healthy female. She got diagnosed in May of 2016. She had stage 2 right breast cancer. It was ER/PR negative, HER2 positive. She did neoadjuvant chemotherapy. After that, she had a bilateral mastectomy, which was in November of 2016. She had a complete pathological response. She did have reconstruction. At the time of her mastectomy, she had expanders put in. She went on to do an implant exchange afterwards. She had some rehab in between that. She had some myofascial restrictions from the impact of her breast surgery and the reconstruction. She went on to do Herceptin for a year and also adjuvant Zometa. In her initial surgery, or her mastectomy surgery, she had a total of 4 negative lymph nodes removed on the right side. So considered a sentinel node biopsy, where her risk would have been between that 4 and 6%. So we were able to get her baseline measurements. In 2016, we were still using our U400 unit, which was the first LDEX unit, which did not give us these graphs. But we have her measurements in the chart. So from 2016 until 2018, she stayed relatively in the normal range. She never triggered in her measurements. But in the latter part of 2018, she started to have some fluctuations. She had one jump in 2018 that would have put her into the yellow. So we started treating her with, we taught her how to do self-massage, gave her a compression garment, and she came back for follow-ups with that. And over time, this is her graph. So this is about every 3 months for 2019, where she's stayed here in the normal range and slowly increased into the yellow. So we would have her start doing her self-MLD. She said, oh, I stopped doing it for a little while. When it felt normal, when her arm felt okay, she stopped doing it. So she had this fluctuation that just went up and down. And there really wasn't anything else changing in her life. She wasn't gaining a lot of weight or losing a lot of weight. She wasn't exercising more or less than she was before. These were just fluctuations in her arm. And so when she comes down, is in this time when she's in the green, she admits to being very good about doing her self-massage once a day and wearing her compression sleeve, maybe not all day, but during higher risk activities when she is exercising, or if it's really hot and humid and she's gone for a walk, she'll put it on afterwards. So she's never gotten into the chronic lymphedema phase, and this is now going on year 5 for her. After her treatment, though, was in 16, so it's really year 7. So we have been successfully, because of this technology, able to keep her from ever getting any visible swelling. So what's next? We are continuing to expand our lymphedema program and the SOZO technology across our delivery network. We have multiple lymphedema therapists across our delivery network already. And as we expand our use in this technology, we can also use some of this data to help us understand more risk stratification. And really, we don't know why one person gets it and one person doesn't. A lot of times there isn't a reason why somebody triggered. And we can also extend this to other diagnoses. We can use it for prostate cancers who have inguinal lymph nodes removed, and gynecologic cancers, as well as melanomas, and using the same kind of early detection for lymphedema. On a technology side, they are working on advancing this technology so that we can include utilizing it for measurements in the breast for breast swelling, as well as in the head for head and neck cancers. Those are areas that it doesn't measure. Right now, it only measures the arms and the legs. So hopefully in the future, we'll see some more changes coming along. And that is all I have. So thank you. And I'm going to stop sharing my screen. And we have some questions, so let's see. So one question is, I was diagnosed with lymphedema tardia 30 years ago and can testify to the importance of exercise, nutrition, and constant compression. Yes, so that lymphedema tardia is a primary lymphedema where, the lymphedema tardia triggers around the age of 30, 35. It's that late onset of primary lymphedema. So I'm glad that exercise and nutrition and keeping up with that constant compression is very good for you. The technology, so would it work for lymphedema tardia? Would it work for primary lymphedema? Sure, if you had somebody would come into the clinic with a swelling already, we can put people on who have swelling already, but we know that they have the swelling. So yes, this will confirm to us that you have one leg has more extracellular fluid in it than the other leg. We can see that. It just tells us that one leg, yes, is bigger than the other. We're using it more for the early detection where we would see it before we're using it so that we trigger it before we see the swelling. So we don't really use it on an everyday basis to measure our people who have lymphedema already. We'll still use the tape measures for that. We can use pyrometry. There's a couple of other devices that you can use to quantify how much fluid is in the limb. But if somebody, we don't know who's going to get primary lymphedema sometimes. If you're born with it, you have it your whole life. So we already know the swelling is there. But we can put you on it to confirm. Sometimes people come into the clinic and they're like, I think I have lymphedema. And we're like, nope, it's just fat. So there is that whole section of fat disorders. There's one called lipedema, which many times can have a combination of lymphedema and it's a fat disorder. So we can, we can help to diagnose that a little bit easier by saying, well, there really isn't a lot of extra fluid. You're more of a lipedema patient versus lymphedema. And we have a question about, does the 4 to 6% risk of sentinel lymph node increase with radiation and Taxol? It increases, but not very much. So the 4 to 6 includes the radiation. Some studies have showed the sentinel node biopsy with radiation can go up to about 7%. And with the Taxol, it still stays all under 9 to 10%. So it really is still pretty low right now. It's really hard to get solid, accurate percentages and numbers because a lot of times lymphedema goes undiagnosed, or, you know, it's along with swelling or radiation or an infection where they say, oh, it'll go away. And sometimes it doesn't go away. Sometimes it's mild enough where it doesn't bother the person, or a lot of times there's fluctuations. So you'll have a swollen hand and then the next day it won't be swollen, and 4 days later it'll swell again, and then it won't for 3 months. And sometimes there's lots of variations and fluctuations. So there isn't really a good way to get the risk percentages at this point. Hopefully over time that will improve with more people getting diagnosed and being able to use technology like this to gather that data and see if we can get better risk stratification. So thank you all for joining us. If anybody else has any other questions, feel free to put them into the chat. I think I got them all. Thank you to both of our speakers as well for joining us. And I am going to just let everybody know that next week, same time, Thursday at 6 o'clock, we will have another Smilow Shares for our breast education, which will focus on surgical advances, and that will be moderated by Dr. Barbara Ward. So we hope you all can join us then, and thank you.